All right, let's talk about something you're going to see again and again on the wards. It's that patient with pancreatic cancer who, out of the blue, develops atrial fibrillation. It might seem like two separate problems, but they are deeply connected, and figuring that out is absolutely crucial, especially when surgery is on the table. So here's how we're going to break this down. We'll start with the puzzle you'll see right at the bedside. Then we'll get into the hard numbers to see just how big this risk really is. After that, we'll dive into the biology, the why behind it all. Then we'll look at the real-world consequences for these patients. And finally, the most important part, what you can do to manage this dual threat. So let's start with that core question, the one you'll be asking yourself as you're doing your rounds. You've probably already noticed this, or you will very soon. A patient with pancreatic cancer seems to be doing okay, and then boom, new onset AFib. I really want you to hear this. That is not a coincidence. It is a direct result of their cancer, and it has a huge impact on their entire clinical course. Here's the key concept to lock in your mind. The cancer itself creates an environment in the body that makes the heart prone to arrhythmias. It's what we call a proarrhythmic state. This means the cancer is an independent risk factor for AFib. You can't just chalk it up to old age or other health problems. The malignancy itself is a major player here. Okay, so we've established there's a connection. But just how strong is it? Let's put some real numbers on this to appreciate the scale of the problem. Take a look at this number. It comes from a really large study, and what it tells us is that for every 10,000 years of patient follow-up, we're seeing over 105 new cases of AFib pop up in our pancreatic cancer patients. That gives you a very real sense of just how common this complication is and why you need to be watching for it. And this isn't just something we're seeing in one hospital or one region. This data is global. It shows a clear, straight line. In countries where pancreatic cancer rates go up, AFib rates go up right alongside them. When you see a pattern that strong on a global scale, you know there's a deep biological link at play. Now, as with so many things in medicine, age is a massive game changer here. Look at these bars. For patients under 65, the risk is definitely there. But for our patients 65 and older, the risk just skyrockets. It's more than 5 times higher. This means for every elderly patient you see with pancreatic cancer, your antenna for new onset AFib needs to be way, way up. So we've firmly established that there's a link. Now for the really fascinating part. Why is this happening? Let's get into the shared biology. It's not just one thing. It's a perfect storm. The cancer itself causes this chronic systemic inflammation and puts the body in a hypercoagulable state, making blood clots more likely. It also messes with the autonomic nervous system. Then you layer on top of that all the usual suspects, the shared risk factors like age, obesity, and diabetes, and you've basically created the perfect recipe for AFib. This diagram here really pulls it all together beautifully. Just picture the heart's atria getting attacked from all sides. You've got insults from the cancer itself, from the chemo and radiation we use to treat it, and from the patient's other health problems. All of this leads to what we call atrial remodeling, physical and electrical changes in the heart's upper chambers. That damaged tissue becomes the perfect breeding ground for an arrhythmia like AFib. And let's focus on this one for a second, because it's a huge piece of the puzzle: autonomic dysfunction. Think of it like the body's gas pedal and brake pedal, the sympathetic and parasympathetic systems being completely out of whack. The cancer throws that delicate balance off, sending chaotic signals to the heart. This directly messes with the electrical stability of the atria, making them ripe for AFib. Okay, so that's the science behind it. But why does this matter to you when you're on call, getting a patient ready for a major surgery like a Whipple? Let's bring this back to the clinic. Get this number. A huge national study found that 10%, 1 out of every 10 patients going for a Whipple procedure, already had AFib before they even got to the operating room. Just let that sink in. A significant chunk of these incredibly high-risk surgical patients are walking in with a major cardiac issue already on board. And the difference in how they do after surgery? It is night and day. The patients with AFib have way more complications, they stay in the hospital longer, and the care costs more. This isn't some minor issue on their problem list. It's a major predictor of a stormy postoperative course. And we are not talking about small problems here. We're talking about the big, scary stuff. Significantly higher rates of major cardiac events, respiratory failure, pulmonary embolisms, and perioperative shock. The presence of AFib is a massive red flag for a very, very tough post-op journey. So all of this leads to the most critical question of all. What are we supposed to do about it? How do we step in and manage this dual threat to give our patients the best possible outcome? Your game plan really comes down to these three essential steps. 1. Assess. Every single one of these patients needs a thorough cardiac workup before surgery, no exceptions. 2. Plan. You have to have a rock-solid, meticulous plan for their anticoagulation around the time of surgery. That's a tricky balancing act. And 3. Collaborate. This is non-negotiable. You cannot do this alone. If you take only one thing away today, let it be this. Managing these complex patients is a team sport, period. The surgeon, the cardiologist, the anesthesiologist, everyone needs to be talking. Everyone needs to be on the same page with a shared plan before that patient ever sets foot in the OR. And this all points to a much bigger question about where our field is headed. Both cancer and AFib are becoming more common. So we have to ask ourselves, is the old way of doing things, just getting a quick consult here and there, really good enough anymore? Or do we need to build dedicated cardio-oncology teams to make this kind of collaborative care the standard for every patient? That's something we're all going to have to think about.